Pulmonary rehabilitation is a comprehensive program based on a thorough patient assessment and individualized treatment. It is designed to improve both the physical and psychological conditions of people with chronic respiratory diseases.
This clinical program is indicated for patients with chronic respiratory diseases like COPD, bronchiectasis, lung cancer, interstitial lung disease, and asthma.
The essential components of the program include the following: education, exercise training, and psychosocial support.
Pulmonary rehabilitation improves the patient's exercise capacity, quality of life, reduces exacerbation and hospital confinement, and can lead to a reduction in anxiety and depression.
Di na kami nag-iisa.
Kasama na namin
ng pulmonary rehab. Tara na!
Let us all join hands and celebrate the National Pulmonary Rehabilitation Day.
Happy National Pulmonary Rehabilitation Day!
Breathe better. Live better with pulmonary rehabilitation.
Our Heavenly Father, with humble hearts and contrite spirits, we come before Thee now in solemn prayer to give Thee thanks for the gift of healing that Thou hast placed in our hands, that through it we may restore that which was lost. We give Thee thanks for our talents, that even when we lose everything, we will always have something to share. We give Thee thanks for our differences, that through them our existence may become exciting and filled with color. We give Thee thanks for our weaknesses, that through them we may be humbled. We give Thee thanks for bringing to our awareness the weaknesses of our brothers, that by knowing, we may become better friends to them. We ask Thee now, dear Father, to help us use our abilities to build and strengthen one another. We ask Thee to help us use our intellects not for our own aggrandizement, but to give praise to those who are worthy of praise. We ask Thee to replace our pride with an appreciating eye, that we may recognize the worth of others. We ask Thee to teach us how to be mindful of our calling, which is sometimes to cure, most of the time to alleviate, but always to give comfort. Lastly, help us become worthy to be called instruments of Thine healing power. In the name of Jesus Christ, Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, helas ng sinakanan, alam ng puso.
Share one mission as we take this noble quest, searching for wrong, armed with a right. This is our oath and commitment, drawing strength from each other. We are proud of who we are. Against all odds, for we are brothers. Step by step we will conquer. Humble yet strong, prudent but brave, aiming higher and higher. Eyes looking up, but feet on the ground. Sharing vision, one true faith, one golden dream, to be the best among the rest. Together we can, if we believe we can achieve. Together we can become
Hello, good evening, everyone. Tonight is an exciting event as we are celebrating the first Pulmonary Rehabilitation Day. Tonight's session is entitled Restoring Within, Exploring the Current Forms and Application of Pulmonary Rehabilitation. Without further ado, I would like to call on Dr. Maria Janet Samson, the President of Philippine College of Chest Physicians, for she has some words in line for today's activity.
Good evening. Evidence magnified during the COVID pandemic, giving a wider perspective of indications for pulmonary rehab. We have seen how pulmonary rehab allow our patients to bridge the gap from treatment of their acute illnesses to reclaiming their old lives. With the revival of Ad hoc Council on Pulmonary Rehab under the leadership of Dr. Percy Ponsal, we have seen the renewed interest in bringing forth awareness of the benefits of pulmonary rehab and enhancing the quality of life of our patients. Furthermore, the declaration of June 19 as a National Pulmonary Rehab Day is a testament of his persistent efforts to put emphasis on the Council's advocacy. In behalf of the Board of Trustees of the Philippine College of Chest Physicians, we congratulate and extend our deepest gratitude to the Ad hoc Council on Pulmonary Rehab for taking on this advocacy and sharing their expertise. Tonight, through our invited experts, we will discuss the advances in pulmonary rehab and a wide array of indications which will improve our patients' outcome. Thank you and good evening.
Thank you, Dr. Samson, for the warm opening remarks. As we go along, allow me to introduce Dr. Percival Punsal. Dr. Percival Punsal is a pulmonary rehabilitation specialist in the Philippine Heart Center. He is a fellow of the Philippine College of Chest Physicians, and nonetheless, he is the chairman of the Ad hoc Council for the Pulmonary Rehabilitation.
Thank you, Nico. First, I would like to greet everybody. Happy National Pulmonary Rehabilitation Day. For us, this is a milestone because this is the first time in the country where this commemoration is being done. There are so many people to thank that made us realize the events that occurred today. We have our training fellows, we have our pulmonary consultants, we have the board, we have the members of the council of pulmonary, or rather the ad hoc committee of pulmonary rehab, and we have Joanne and his staff at PCCP. So these are all important people that has been the instruments for us to come up with this type of celebration. At this point, I would like to acknowledge, we have an international audience right now. I saw the name of Dr. Kim San Chang. KS Chan is actually one of the pioneers in Hong Kong of pulmonary rehabilitation. Dr. Chang, welcome and thank you very much for joining us tonight. It was intentional on our part in the ad hoc committee to choose our young and upcoming colleagues to act as speakers tonight. They are among the best in the crop, and I am very confident that they will be able to bring us the different updates that you would like to know about pulmonary rehabilitation. The idea of this symposium is really to give updates and awareness among our healthcare workers on the importance and advancements in the field of pulmonary rehabilitation. Without much further ado, I would like to thank everybody for joining us tonight. Thank you very much and good evening.
Thank you, Dr. Percival Punzal, for that very inspiring message. So allow me to call on the first speaker, Dr. Karen Ann Claridad. So Karen Ann Claridad had her education and training for Doctor of Medicine at the Cebu Institute of Medicine, IM residency training at the Chonghua Hospital, and adult pulmonary medicine training at the Philippine General Hospital. Other post-fellowship training includes observership training at the Pulmonary Rehabilitation St. Luke's Medical Center, Global City, and Pulmonary Rehabilitation at Yonsei University College of Medicine, Gangnam Severance Hospital at South Korea. So Dr. Karen Ann Claridad, I think she's already ready.
Okay. Thank you, Dr. Dalisay, for the introduction, and thank you to the Council of Pulmonary Rehabilitation and Dr. Punzal for the invitation to discuss on the advances in pulmonary rehabilitation, the contemporary practices in the local and global settings. Okay, so I have nothing to disclose, and this will be the outline of my discussion. Okay, so we will briefly discuss or go through the global and local impact of COPD, and I will be presenting the different modes of delivery of pulmonary rehabilitation and the application of pulmonary rehabilitation in other lung conditions. Okay. Now, according to the World Health Organization, there are about 65 million people suffering from moderate to severe COPD. Now, COPD is considered as the third leading cause of death worldwide. Unfortunately, nearly 90% of COPD deaths in those under 90 years of age occur in low and middle income countries, to which Philippines belong to. And locally, based on studies, the prevalence of COPD in rural areas is as high as 20.8%, and in Metro-Manila alone, it's at 12.8%. And COPD is considered as the seventh leading cause of mortality in our country. Now, let us try to understand why COPD is associated with a very high mortality beyond its effect on declining lung function. Now, patients with COPD experience the following extrapulmonary treatable traits. So you have your impaired exercise capacity, you have difficulty with activities of daily living, poor quality of life, anxiety, and depression. Now, all in all, these extrapulmonary traits contribute to the downward spiral in COPD, which basically begins with breathlessness, and then there will be increase in activity, eventually leading to deconditioning. Now, the moment these patients begin to move again, okay, they do some activity, they will experience more profound breathlessness, forcing them to somehow decrease their activity even more so, as for them not to experience so much dyspnea, okay? Now, this worsens their deconditioning, translating to increased disability and mortality. Now, that is the concept of the downward spiral in your COPD. Now, these patients, once they go through the downward spiral of COPD, with concurrent decline in lung function, they will have increased risk of exacerbation, which increases the risk for hospitalization. And moreover, discharge from the hospital after a severe exacerbation is associated with an increased risk of readmission. Now, with all these facts on the table, efforts to reduce recurrent exacerbations and hospitalizations must be made to improve patient outcomes and reduce societal burden, as hospitalizations alone account for up to 70% of all COPD-related costs. Now, in order for us to break this chain in COPD, aside from optimization of pharmacological interventions, we must also incorporate pulmonary rehabilitation, which is a non-pharmacologic intervention appropriate for most symptomatic patients with respiratory disease that is impairing their quality of life. Now, this intervention, which is already considered a standard care in patients with COPD, aims to improve the physiological and psychological condition of participants through exercise training accompanied by education and behavior change. So take note, pulmonary rehabilitation is not merely letting the patient exercise, but there should be incorporation of education and subsequent behavior change on the part of the patient. Now, pulmonary rehabilitation improves symptoms, quality of life, healthcare utilization, and may even improve survival in patients with chronic respiratory disease. Now, despite the evidence on the benefits of pulmonary rehabilitation, the utilization of pulmonary rehabilitation worldwide remains to be low. So it's not just actually a local issue here in our country, but rather a global concern that most patients who are eligible for pulmonary rehabilitation do not participate in the program. Now, the referral rates to PR after an exacerbation is actually very low, and only 1.5% of patients are reported to initiate PR within 90 days of discharge, and fewer than 10% of patients complete the program. Sustaining long-term adherence to exercise training is difficult, basically because of the disease progression with intervening exacerbations, so they get admitted every now and then. There are variation in day-to-day conditions, and because of the different barriers identified, which are, the issues on access, uptake, and completion, which are key challenges facing pulmonary rehabilitation programs around the world. Now, in order for these concerns to be addressed, new models of pulmonary rehabilitation delivery are introduced, which are promising alternatives to the traditional pulmonary rehabilitation and maintenance strategies. Now, traditionally, pulmonary rehabilitation is delivered in person on an outpatient basis at a hospital. However, newer alternative modes of pulmonary rehabilitation delivery will include home-based or community-based models, and they use of telehealth. Now, in community-based pulmonary rehabilitation, there are healthcare facilities located within the community which have physiotherapists and respiratory therapists facilitating the rehabilitation. So these are actually like satellite centers distributed within the radius of a certain community to make the program more accessible to patients. Now, the setting would be after the patients are discharged from a hospital, they are referred to a community-based rehab center for PR initiation and continuation or maintenance phase. And that's basically the setup for your community-based pulmonary rehabilitation. Telerehabilitation, on the other hand, is the delivery of rehabilitation services at a distance using information and communication technology. Okay. Now, telerehabilitation is the utilization of information and communication technologies to provide rehabilitation services remotely to people in their homes. Now, this will still encompass a range of services that include assessment, monitoring, prevention, intervention, supervision, education, consultation, and counseling. So basically, all interventions that are being done in the hospital setting are still being done through telerehabilitation. Now, telerehabilitation is done in different ways, in different centers, in different countries. Now, one setup would be through video conferencing, wherein the therapist is in the hospital and the patient is at home. Now, through video conferencing, the patient is instructed to do the exercises, and there will be feedback provided from by the therapist as the patient is seen doing the exercise real time. Now, video conferencing is done each time the patient does the exercise. So meaning to say all exercises are still supervised. Now, another mode would be through the use of mobile devices or computers or different applications in which the exercise prescription is provided online and the patient does the rehab unsupervised and the patient himself records his own progress through the application in his mobile phone or through his laptop. Now, there will be real-time video conferencing done every now and then, sometimes done once weekly to ensure the quality of rehabilitation, but most of the exercises are unsupervised. Now, these two strategies improve uptake and access to PR and support long-term maintenance. Now, the question, what is the level of evidence for telerehabilitation versus a hospital-based or in-person pulmonary rehabilitation? Now, there was a Cochrane systematic review that was published in 2021, which investigated this one. And based on this study, they found that there is actually little or no difference between telerehabilitation and in-person pulmonary rehabilitation in terms of exercise capacity as measured by 6-minute walking distance. And they also found out that there is little or no difference for quality of life measured with if you're trying to measure your health-related quality of life through your SGRQ. And based on these studies, they found out, of course, that participants were more likely to complete a program of telerehabilitation with 93% completion rate as compared to 70% in face-to-face in-hospital rehabilitation. Based on this study, there were no safety issues identified. However, you have to take note that in those studies providing this evidence, prior to conducting a telerehabilitation, a face-to-face assessment was done in all patients, in all subjects. And the face-to-face evaluation ensures safety for the participants and also provides adequate exercise tolerance evaluation through your 6-minute walk test, as your 6-minute walk test can never be done remotely. Remember, there is a standard protocol provided by the ATS for the conduct of your 6-minute walk test. Okay. Now, as I mentioned earlier, there are different ways on how telerehabilitation is delivered across the world, different countries in the world. Now, one mode of delivery is through the creation of a web-based pulmonary rehabilitation program. So this is an example from the Lung Foundation, Australia. So this is an interactive website wherein the patient can actually find a pulmonary rehabilitation class that is nearest, or a pulmonary rehabilitation center that is nearest to his place, and also provides him with the information needed for regarding pulmonary rehabilitation. So this is still a 6 to 8 week program led by healthcare professionals. Now, if you try to explore more the website, you can see here that it gives you the option to choose whether you would like to have both in-person and online, so like a hybrid or telerehabilitation, or an inpatient only, or an online rehabilitation. And also you can choose here how far you would want your centers to be. So it helps you locate the nearest rehabilitation center in your place. Okay. Now, another example of a web-based pulmonary rehabilitation would be the one from ATS. It's called Live Better with Pulmonary Rehab. So still, it provides you the information needed regarding pulmonary rehabilitation. So patients can access this for free, and also allows the patient to locate the nearest pulmonary rehabilitation center in their area. Okay. Now, another mode of delivery is through real-time video conferencing, as what was mentioned earlier, in which all exercises are supervised but done remotely. Here is an example of the setup here. So you can see here the therapist is at the hospital. Okay. The patient is at home, and then at home, the patient's camera is turned on and instructions are being given by the therapist, and there will be feedback given by the therapist as the patient does the exercise. So basically, all exercises are still supervised. So we do this 2 to 3 times per day, 2 to 3 times per week, and the other days, the patient can do his exercises unsupervised. Now, in our institution, in our pulmonary rehabilitation package, this is something that we incorporated as well, and something that we find very useful. So all patients who are enrolled in our program will have this exercise booklet. Okay, so this actually guides them on the different exercises that they can do at home. So most of our patients, when they enroll in the program, they will really ask, Doc, can we have a list of exercises so that we can do the exercise even if we are out of schedule? So, and also when they graduate from the program, they would also ask for a list of exercises that they can continue even after graduating from the program. So on this guide, on this booklet, all of the exercises from warm up until cool down is being provided with the instructions on how to do or how to properly perform them. Okay. Now, let me now proceed to the second part of my discussion, which is the utility of pulmonary rehabilitation in other lung disease. Okay. Now, most of the evidence supporting the benefit of pulmonary rehabilitation has derived from studies of patients with COPD, right? However, results obtained in patients with respiratory diseases different from COPD have provided evidence that the benefits from PR are also observed in symptomatic patients with other respiratory diseases. Now, here is the list of the different conditions appropriate for pulmonary rehabilitation as recommended by the American Association of Cardiovascular and Pulmonary Rehabilitation. So as you can see here, the different obstructive lung disease, we have your asthma, COPD, asthma, we have bronchiectasis, restrictive lung diseases, including ILD, chest wall diseases, including kyphoscoliosis, neuromuscular diseases, which will be discussed later on as well, and other conditions such as lung cancer, primary pulmonary hypertension, before and after surgery, be it a thoracic or upper abdominal surgery, lung transplantation, or lung volume reduction surgery. Now let's go through the evidence of PR on these diseases one by one, starting with your interstitial lung disease. Now, based on ATS, there is already a strong recommendation for adults with ILD to undergo pulmonary rehabilitation, and this is based on moderate quality of evidence. Now, interstitial lung disease is characterized by progressive decline in lung function, hypoxemia, and is associated with high mortality. Cardinal feature in ILD is reduction in exercise capacity, which is associated with worse survival. And studies, based on studies, PR can improve 6-minute walk test, distance, and also health-related quality of life. However, you must take note that as compared to other lung disease, let's say, for example, COPD, patients with ILD experience profound exertional oxygen desaturation, and most of them are already on long-term oxygen therapy. So you might really want to make some adjustment in terms of your exercise prescription for patients with ILD. Okay. Now, another condition that can benefit from pulmonary rehabilitation would be your non-cystic fibrosis bronchiectasis. Now, based on this algorithm, you can see here that pulmonary rehabilitation is already part of the first line treatment or management for your bronchiectasis. Okay. Now, proponents of exercise consider it to be a form, your pulmonary rehabilitation is a form of airway clearance, but the benefits of pulmonary rehabilitation actually extend beyond mobilization of secretions in patients with bronchiectasis. There's actually a retrospective study in which patients with non-cystic fibrosis bronchiectasis and exertional dyspnea are enrolled and participated in 6 to 8 weeks of twice-weekly supervised exercise sessions of walking, cycling, and strengthening exercises. And this study showed significant improvement in 6-minute walk distance and health-related quality of life. In another retrospective study on the effects of similar exercise program, patients also showed significant improvement not only in exercise capacity, but also required fewer emergency room and outpatient visits, as well as decreased need for short-acting bronchodilators. Now, another condition would be your lung cancer. Okay, as part of the palliative care. We'll not be discussing this one thoroughly because we will have a separate discussion on this later by Dr. Monera. But pulmonary rehabilitation is now becoming a part of supportive care for patients undergoing chemotherapy and radiation therapy for lung cancer. Now, the ability to be more active without suffering the consequences of dyspnea on exertion actually boosts the patient's self-efficacy and allows for an improved quality of life so that lung cancer patients can participate in their family lives during this therapeutic challenge. Now, another condition that will benefit from pulmonary rehabilitation would be your long COVID. Now, COVID-19 survivors face the risk of long-term sequelae of the disease, and the two most frequently reported long COVID symptoms are your shortness of breath and fatigue, which can last for months after infection in as many as 50% of patients. Now, based on studies, PR can improve tolerance to submaximal exercise in the distance walk on 6-minute walk test, can reduce dyspnea in your MMRC, and can increase muscle mass in the upper limbs. However, since long COVID is still a relatively novel condition, future studies are still needed to establish the optimal pulmonary rehabilitation protocol and the duration for the rehabilitation recommended for these patients. Okay. Now, another set of patients benefiting from pulmonary rehabilitation would be your patients with neuromuscular disease. Now, NMD patients suffer from progressive muscle weakness along with this, there is respiratory muscle weakness that can cause hypercapnia, okay? And then your hypercapnia can increase gradually as the disease progresses. Now, the fundamental respiratory problems in NMD are due to decreased alveolar ventilation and decreased coughing ability. Now, as part of pulmonary rehabilitation in patients with NMD, respiratory support by mechanical ventilation should be initiated. So it could either be through non-invasive or invasive methods to relieve respiratory distress. Okay. Now, for those with decreased cough ability, strategies to assist coughing will be necessary, such as the provision of lung insufflation plus an abdominal thrust to make coughing more efficient. Use of mechanical exsufflation devices are also effective in clearing secretions and in preventing atelectasis. Now, these interventions, based on the study by Professor Kang, have made it possible to maintain a better quality of life in addition to prolonging the lifespan of patients with neuromuscular disease. Now, what are the different neuromuscular disease that we are talking about? Okay, so this can include your ALS, GBS, you have your Duchenne and Becker muscle dystrophy, you have your spinal muscle atrophy, and even severe kyphoscoliosis causing restrictive lung disease. Okay, now let me share to you this news report in Korea, wherein a pulmonary rehabilitation is being implemented for patients with neuromuscular disease.
A special ceremony took place to celebrate the entrance and graduation of patients who are suffering from a rare type of muscle disease. Just like Stephen Hawking, the world-renowned physicist who suffered from a similar disease, these students didn't let their condition stop them from pursuing higher education. Our Kim Jung-sil has the story.
A moment to celebrate the years of hard work for the 18 students who are either entering their freshman year of college, continuing with their studies, or graduating with a diploma. All suffer from different types and levels of muscular dystrophy, a rare muscle-related disease that can hinder people from walking, talking, and even breathing. At the Pulmonary Rehabilitation Center here at Yonsei Gangnam Severance Hospital, customized treatment for each individual has enabled these students to finish school. Meet soon-to-be college freshman Minu, who was diagnosed with spinal muscular atrophy, or SMA, at the age of 5, a genetic disease that significantly weakens muscles, making it difficult to breathe or concentrate. But the treatment at the center helped him overcome some of the difficulties.
네, 그것도 있고 체력적으로도 좀 더 오랜 시간 앉아 있을 수 있게도 해주고 합니다.
Dr. Min Kyung-hyun, on the other hand, recently got his PhD degree in physics from Yonsei University. Calling himself a huge admirer of British physicist Stephen Hawking, Dr. Min wrote his graduation thesis using just one index finger on his keyboard.
뭔가 제가 도움이 되거나 할 수 있는 게 있으면 뭐 취업을 하든 뭐 저희 교수님께서 생각이 좀 했으면 좋겠다고 하시는데 뭐 가능하면 뭐든지 도움이 되는 이런.
Professor Kang Sung-woo looked over all of these students.
All I did was just help them breathe better. They couldn't even click a mouse button freely. And look at what they've achieved. It's so inspiring. As a doctor, I feel extremely rewarded.
He also said,
Okay, so that news report was very interesting, showing us the utility of pulmonary rehabilitation in patients with neuromuscular disease. Now, in summary, there is a strong evidence existing on the benefits of pulmonary rehabilitation in chronic lung disease. And despite this strong evidence, there are still barriers to pulmonary rehabilitation, including issues on access, uptake, and completion. And to break these barriers, novel models of PR delivery are being implemented. And as the last part of my lecture, other lung conditions that can benefit from PR include bronchiectasis, ILD, long COVID, lung cancer, and neuromuscular disease. Now, that will be the end of my presentation, my lecture. In behalf of all the pulmonologists here in Central Visayas, would like to greet everyone a happy National Pulmonary Rehabilitation Day.
Thank you, Dr. Karen, for that very informative lecture. So I would like to inform everyone that questions will be entertained after all of the lectures. So you can post them on the chat box provided. So questions will be addressed during the short open forum after the third lecture. So for the next lecture, may I call on Dr. Omohaire Dilangalen. So Dr. Omohaire Dilangalen had her education and training and Doctor of Medicine at the Davao Medical School Foundation, IM residency training at the San Pedro Hospital of Davao, adult pulmonary and critical care medicine training at the Philippine Heart Center, and subsequently had her clinical research fellowship for pulmonary rehabilitation at the same institution. So may I call on Dr. Dilangalen.
Okay, good evening, everyone. Okay. Chronic obstructive pulmonary disease remains among the top 10 leading causes of mortality in the Philippines. Whereas COPD is an obstructive and progressive airway disease, it is also associated with significant reduction in physical activity, which contribute to the patient's disability and poor health-related quality of life. For a long time, the treatment of COPD has focused mainly on pharmacological improvement of the airway obstruction. However, Over the last 2 decades, growing evidence of systemic manifestation of COPD patients and their negative effects on the functioning of these patients has accelerated the development and use of non-pharmacologic treatments such as pulmonary rehabilitation. Tonight's talk outlines the impact of COPD on physical activity levels and the adverse consequences of low levels of physical activity. We will also highlight the benefits of pulmonary rehabilitation on important patient outcomes. We'll also discuss clinical usefulness of PR in COPD, focusing on exercise training, which provides patients a favorable environment for optimizing therapy. And also, we hope to stimulate pulmonary physicians to use pulmonary rehabilitation more often. COPD is a chronic airway disease mainly caused by tobacco smoking, leading to progressive dyspnea. COPD has a substantial manifestation beyond the lungs, the so-called systemic effects, such as unintentional weight loss and skeletal muscle dysfunction. The chronic systemic inflammation that is linked to COPD may also initiate or exacerbate comorbid diseases and is one of the key mechanisms underlying these extrapulmonary effects. The pathophysiology behind exercise limitation in COPD is multifactorial, but ventilatory, cardiovascular, or limb muscle dysfunction may dominate the phenotype across all COPD severities. So here we will focus mainly on the impaired pulmonary gas exchange due to diffusion limitation as a limiting step in the oxygen transport cascade. So look at this figure. The convective oxygen transport from ambient air to the alveolar capillary interface is limited by mechanical restraints on the ventilation due to narrowing of the peripheral airways or obstruction that is associated with both an abnormal breathing pattern, dynamic hyperinflation, an increased work of breathing, which are all interconnected through a neuromechanical dissociation. Now, with that, there is a reduced alveolar capillary reserve. The convective oxygen transport through circulation may be attenuated via the lower cardiac output response during exercise and or an imbalance between the systemic vasodilation and vasoconstriction. Now, because of this, the convective transport of oxygen to the working muscle may be critically low even when the oxygen content of the arterial blood is maintained. Furthermore, the skeletal muscle, particularly the lower limbs, is sarcopenic with a low oxidative intramuscular phenotype that encompasses a fiber shift from type 1 to type 2A. And there's also an altered capillarization of these fibers. Now, these alterations can lead to higher concentrations of lactate for a given work, which stimulate ventilation, provoking dynamic hyperinflation and thus increasing the ventilatory burden. Moreover, there is also it also induces an increased susceptibility for muscle to fatigue, and so that they terminate the exercise too early. Dyspnea on exertion is common in people with COPD and leads to avoidance of daily activities that elicit this symptom. This results in the downward spiral of progressive inactivity with adverse consequences that includes peripheral muscle deconditioning, depression, social isolation, and poor quality of life. Regular exercise implemented in pulmonary rehabilitation programs is considered the most effective therapeutic intervention for breaking this pattern. Now, physical activity, WHO defines physical activity as any bodily movement produced by skeletal muscles that requires energy expenditure. Physical activity in daily life can be categorized into occupational, sports, conditioning, household, and other activities. Exercise is a subset of physical activity that is planned, structured, and repetitive with a goal or an objective to improve or maintain physical fitness. The updated statement by the American Thoracic Society and the European Respiratory Society Task Force on Pulmonary Rehabilitation defined pulmonary rehabilitation as a comprehensive intervention based on a thorough patient assessment followed by a patient-tailored therapies that include but are not limited to exercise training, education, and behavioral change, designed to improve the physical and psychological condition of people with chronic respiratory diseases and to promote the long-term adherence to health-enhancing behavior. Now, looking at this definition, it really does emphasize that pulmonary rehabilitation is a well-proven, structured, and multidisciplinary treatment approach. A pulmonary rehabilitation is not a standalone therapy, but rather it's something that should be integrated into the management program, wherein the doctors, the general practitioner, and the pulmonary specialist take active part. So that pulmonary rehabilitation aims to break the aforementioned vicious cycle in COPD. Based on various published RCTs and meta-analysis, numerous evidence-based reviews have evaluated the effect of PR on symptomatic COPD patients. These have demonstrated effectiveness and utility of PR. The main outcomes include exercise performance, dyspnea, health-related quality of life, psychosocial benefits, reduced healthcare utilization, and survival have been reported. The benefits on many laboratory and clinical parameters associated with pulmonary rehabilitation are produced even without demonstrable improvements in the pulmonary function. Pulmonary rehabilitation is a comprehensive, multidisciplinary, multi-component, patient-centered intervention consisting of pre-rehabilitation assessment program, exercise and muscle training, self-management education, occupational therapy, psychosocial support, and nutrition intervention. Although most programs include these aspects, they may vary considerably from one center to another. The structure and setting of PR may vary widely around the world. PR programs can be conducted with benefits in inpatient, hospital, community-based outpatient, or home-based settings. The choice of settings remain a question of patient motivation, disease severity, and complex comorbidities, local program availability, and available resources. The minimum duration of effective ambulatory pulmonary rehab program is currently unknown, but GOLD guidelines suggest 6 weeks. It appears that there is a minimum of 20 sessions needed to achieve physiological benefits, although longer programs are associated with better results. Pre-rehab assessment program. Assessment of the patient prior to initiation of pulmonary rehab, but also during and at the end of the pulmonary rehab is an essential element in the practice of pulmonary rehab. It allows the patient to have an individually tailored treatment based on their needs and problems and for adaptation of program of PR according to the progress obtained. Assessments include the past medical history, physical examination, 6-minute walk test, pulmonary function test, down the line. The limited number of RCTs comparing different lengths of PR prevents a more definitive conclusion on the optimal duration of pulmonary rehab. Conversely, an interesting meta-analysis conducted that patients with mild to moderate COPD benefit from the short and long-term rehabilitation, whereas patients with severe COPD may benefit from rehabilitation programs of at least 6 months. Exercise training is widely regarded as a cornerstone of pulmonary rehabilitation in patients with chronic obstructive pulmonary disease. Indeed, exercise training has been identified as the best available means of improving muscle function and exercise tolerance in patients with COPD. The basic principle of exercise training is one of progressive overload. That is, by placing greater demands on the body, there will be continued improvement in capacity. So to be able to perform exercise, the ventilatory, cardiovascular, and skeletal muscle systems must be integrated to deliver oxygen to and remove metabolic byproducts from the exercising muscle. With repeated bouts of exercise, these systems are overloaded and the physiological adaptations occur with a result in central cardiac adaptation, wherein there is improvement in the cardiac output via the increased stroke volume, the peripheral or the skeletal muscle adaptation, wherein there is an increase in the oxidative capacity and capillary density of the exercising skeletal muscles. These adaptations improve the delivery and consumption of oxygens at the exercising muscle, both at peak and submaximal workloads. Endurance training is the most common exercise modality in COPD patients. The main objective is to improve aerobic exercise capacity, as aerobic activities are part of the many tasks of the daily living. The exercise training is guided by the following parameters: the type, the intensity, the frequency, and the duration. So, exercise training, what is it about intensity? There is evidence that higher intensity results in greater adaptation to exercise training. So in this study done by Gormley and his associates, subjects were randomly assigned to either a control or to one of the exercise groups, wherein there's moderate at 50%, oxygen uptake reserve, vigorous at 75%, and near maximal at 95% intensity. This table shows that the increase in the oxygen uptake, maximum oxygen uptake, showed a stepwise increase as a function of the training intensity. In contrast, a large study done by Maltese and his associates found no significant difference in the physiological or patient-centered responses to different training entities. While both groups have significant improvement in the functional exercise capacity as measured by the 6-minute walk distance and the health-related quality of life measured by the SGRQ, there were actually no difference between group differences. Data in different studies evaluated in meta-analysis found no significant difference in endurance time between higher and lower intensity training. Based on this meta-analysis, it was concluded that there is limited evidence to compare high versus low-intensity exercise training in COPD, and that a definitive recommendation regarding the optimal intensity of exercise training cannot be provided. The balance between intensity of the exercise training, patient tolerance to such intensity, and the size of the physiological and patient-centered outcome need to be taken into consideration for exercise prescription. All studies demonstrated beneficial response to training at intensities of more than 60% peak work. From this limited pool of evidence, it appears that the patient-centered outcomes are equally improved with training at 60% and 80% peak work. Both low-intensity and high-intensity exercise training produce clinical benefits for patients with COPD. Muscular functional disorders are reversible with moderate to high-intensity rehabilitation exercises with the same magnitude across all GOLD stages from 2 to 4. Low-intensity training results in improvements of symptoms, the health-related quality of life, performance of ADLs, and some aspects of performance of activities associated with daily living. Moreover, with low-intensity training, there is long-term adherence, which seems to be better in low-intensity than in the high-intensity training. However, training programs should attempt to achieve maximal physiologic effects. So high-intensity training is proposed in pulmonary rehab centers. High-intensity training targets have been defined to be at least 60 to 80% of the peak work rate achieved in an incremental maximal exercise test. This intensity seems sufficient to elicit some physiologic training effects. However, for severely breathless COPD patients, it is not possible to achieve certain training targets. So interval exercise regime may be preferred. Here, the continuous exercise session is substituted by a succession of shorter, high-intensity exercise periods alternated with low to moderate intensity exercise recovery periods. Whilst there are a limited number of studies that compared high versus low-intensity continuous exercise training in patients with COPD, there are a great number of studies that compared interval versus continuous exercise training in this patient group. The benefit of interval exercise is that individuals are able to complete repeat bouts of high intensity exercise, although a short period of time, compared with continuous exercise at the same intensity. During interval exercise, COPD patients were able to exercise with lower level of breathlessness and a substantially lower and expiratory lung volume, demonstrating a lower degree of dynamic hyperinflation. The form of training may be more comfortable for patients with more severe dynamic hyperinflation, and the adherence to the treatment may be better. Patients with severe COPD may also increase the total exercise duration with lower metabolic and ventilatory stress while doing an interval training. To date, the most optimal format of exercise training, the type, intensity, frequency, and duration for patients with COPD is still subject to investigation. Accordingly, the major issue of interest has been the selection of appropriate training method that is tailored to the cardiovascular, pulmonary, and peripheral muscular limitations of individual patients so as to maximize the effect of exercise conditioning. Another important component of pulmonary rehabilitation for patients with COPD is education. Patient education, incorporating self-management training, remains an important component of comprehensive pulmonary rehab program, despite the difficulties in measuring its direct contribution to overall outcomes. The content of the education program varies depending on local resources, but the topics most commonly covered are the aspects of the disease, physiotherapy skills, nutrition interventions, energy conservations, and psychosocial interventions. All patients should receive disease education to improve their compliance with medication regimes, oxygen therapy, smoking cessation, nutritional interventions, exercise, and health preservation. So the patient's education aims to equip the patient with knowledge and skill they need to manage their disease and to change their lifestyle, which is the ultimate aim of pulmonary rehabilitation. Chest physiotherapy represents a non-essential component of pulmonary rehab, but proves its usefulness in patients with marked bronchial hypersecretions. Relaxation exercises, flexibility and stretching exercises, breathing techniques such as the pursed lip breathing and diaphragmatic breathing are often coupled with exercise training sessions. These are administered by a brief period of around 5 to 10 minutes and are recommended to maintain muscle length and to prevent injury and soreness. In COPD, nutritional depletion is common and has a negative impact on respiratory as well as on the skeletal muscle functions. And it also contributes to the morbidity and mortality of COPD patients. Achievement of optimal nutritional status should help to maximize the patient's state of health, respiratory muscle function, and overall sense of well-being. The dietitian's role is to establish dietary history, evaluate the BMI, measure the body fat percentage, and ensure dietary follow-up. Anxiety and depression are also important comorbidities of COPD. Quality of life can be assessed by a disease-specific questionnaire such as the Chronic Respiratory Disease Questionnaire or the CRQ and the St. George Respiratory Questionnaire or the SGRQ. The psychosocial intervention for patients include disability evaluation, vocational counseling, and continued education of patient and family. In addition, psychological support can facilitate the adjustment process by encouraging adaptive thoughts and behavior, coping strategies that help patients to reduce their negative emotions, which in turn may improve compliance with pulmonary rehab. Psychological support helps in overcoming addictions, especially tobacco smoking, and along the medical treatment for smoking cessation is an important intervention in pulmonary rehab programs. The benefits of PR program tend to diminish over the months following its discontinuation. Pulmonary rehab programs are usually not associated with sustained benefits beyond 12 months. However, programs lasting for at least 6 months have been more successful in maintaining outcomes, even in the absence of structured maintenance program. Maintenance of benefits of pulmonary rehab, such as physical activity and lifestyle change, is an important challenge for those who have undergone a comprehensive PR program. Many centers currently offer maintenance programs in the hope of consolidating and prolonging the benefits of a successful rehabilitation program. However, the optimal strategy to meet this aim has not yet been described. Available options include monthly supervised reinforcement sessions, home exercise training with or without weekly supervised outpatient sessions, and recurrent pulmonary rehab programs. The best and the most effective maintenance program currently remains to be found. So in conclusion, physical activity levels are reduced in people with COPD. Physiological changes are observed following a structured exercise training program in patients with COPD without changes in the resting lung function. Exercise training is the cornerstone of comprehensive pulmonary rehab program in patients with COPD. And after careful screening, it is safe for COPD patients with comorbidities to obtain significant and clinically relevant improvements in functional exercise capacity and health status after an exercise-based pulmonary rehab program. So that's the last part. And thank you. Happy National Pulmonary Rehabilitation Day.
Okay, thank you, Dr. Omohaire, for that very comprehensive lecture. So as we go on for the last part of our discussion, may I call on Dr. Onaizah Katrina Monera. So Dr. Onaizah Katrina Monera had her education and training for Doctor of Medicine at the University of Santo Tomas Faculty of Medicine and Surgery, IM residency at the Amang Rodriguez Medical Center, and pulmonary fellowship training at the Lung Center of the Philippines. She had further studies for pulmonary rehabilitation fellowship training at the Lung Center of the Philippines, observation training at the Pulmonary Rehabilitation for Lung Transplantation at the Toronto Lung Transplant Program at the Toronto General Hospital in Canada. So may I call on Dr. Monera.
Good evening, everyone. Thanks for staying up to this part of the lecture. The two esteemed speakers that preceded this lecture have already laid out the foundation that pulmonary rehab is already established as part of the management for COPD and other chronic respiratory diseases. But what about lung cancer? It was discussed earlier that pulmonary rehab involves, but is not limited to, behavior change, education, and exercise training. But for this lecture, we will be focusing specifically on the integration of exercise in lung cancer management, its approaches and benefits. This is my outline for tonight. I divided my presentation based on the 4 different lung cancer populations. Number 1, those who will undergo lung resection or those with early stage lung cancer. Number 2, those with advanced stage or inoperable cancer. Number 3, those undergoing treatment and those who have bone metastasis. Lung cancer is the second most common cancer worldwide. And as of January 1, 2022, there are more than 650,000 men and women in the US with history of lung cancer, many of whom were living with metastatic disease. About 80% of these individuals are 65 years of age or older, reflecting the advanced median age of diagnosis. For this year, an estimated more than 600,000 deaths from cancer are expected in the United States. Lung cancer is the leading cause of cancer death among males and among females. Now let's go to the Philippines. This is from the Global Cancer Observatory statistics in 2022. Lung cancer ranked as the number 1 leading cause of death in male and second in females. And it is the second to breast cancer in terms of incidence, mortality, and prevalence here in the Philippines. The primary risk factor for lung cancer is cigarette smoking, which accounts for about 80% of lung cancer causes and deaths. Most patients with lung cancer also have COPD. While patients with COPD and lung cancer have 2 primary causes of dyspnea as well as the conditioning component, pulmonary rehab is effective in alleviating each cause. With progressive dyspnea at lower levels of exertion, the patient fears that his or her life will end with suffocation, and this weighs heavily. Patients may derive symptomatic resolution from bronchodilators, exercise programs, oxygen therapy, and breathing retraining techniques. Pulmonary rehab following hospitalization enables the patient to recover faster, more completely, and with fewer functional limitations from dyspnea, weakness, or fatigue. Lung function may be compromised due to tumor growth, airway obstruction, and impaired gas exchange, giving rise to these symptoms. Psychological distress, anxiety, and depression are also prevalent among lung cancer patients, further impacting their quality of life. Because of these symptoms, it will affect patients' health-related quality of life, cause distress and change in daily physical activity, eventually leading and promoting a cycle of inactivity or immobility and decline in exercise capacity and physical function. Dyspnea is the feared result of any attempt to exert among lung cancer patients. The natural maladaptive response is to avoid dyspnea by becoming inactive, sedentary, and consequently deconditioned. This response adds further dyspnea when the patient does try to exert himself. Thus, inactivity alone is damaging as it impedes the ability of the patient to be active. This is called dyspnea on top of dyspnea. A treatment for lung cancer may be local or systemic, and each treatment is associated with side effects which add to the overall disease burden and impacts on the patient's ability to be physically active. The treatment options for people with lung cancer vary according to the type of lung cancer, stage of the disease, and the patient's functional status. These treatments themselves may also be associated with numerous side effects, commonly presenting as fatigue and weakness. When combined with the symptoms of the cancer itself, it results in higher patient burden and deterioration in many patient-related outcomes, including exercise capacity and physical function. In people with early-stage non-small cell lung cancer, surgical resection of the tumor is the treatment option that offers the best chance of cure. Nearly half of the patients who are alive 2 years after surgery continue to experience increased dyspnea and fatigue when compared with pre-operative levels. Adjuvant therapy such as chemo and radiotherapy can also exacerbate treatment-related symptoms and impairment on top of the usual side effects of these treatments that was discussed in the previous slide. In the local study of Castillo and Cabrera, the incidence of post-op pulmonary complications among patients who underwent VATS was 29.4%. Patients experienced prolonged air leak and nosocomial pneumonia as the most common post-op complication, while the mortality rate was 1.3%. Male gender, smoking history, and smoking of at least 20 years were significant predictors of post-op pulmonary complication, and there was a longer mean hospital stay of 9 days comparing it to the non-neoplastic group who underwent VATS. Now let's see the benefits of exercise in each lung cancer patient group and how we are going to advise which type of exercise best suits them. Pulmonary rehab helps to increase exercise tolerance, allowing patients to engage in daily activities with less difficulty. It assists in reducing dyspnea and fatigue, and that is associated with lung cancer and its treatments by incorporating breathing techniques and energy conservation strategies. Pulmonary rehab addresses emotional challenges faced by lung cancer patients, promoting mental well-being and resilience. And patients who participate in pulmonary rehab may experience better adherence to treatment regimens, leading to more favorable outcomes and reduced hospitalizations. By relieving the patient from the symptomatic burden associated with chemotherapy, pulmonary rehab may enable the patient to tolerate more intense and perhaps more efficacious cancer treatment. Exercise training for the patient who can tolerate it is even more effective in minimizing fatigue and improving aerobic capacity, muscular strength, and physical and functional activity in cancer patients undergoing chemotherapy. Breathing retraining techniques together with exercise reduce inflammation and open airways, leading to a reduction in dyspnea and fatigue. Patients undergoing radiation therapy may experience fatigue and dyspnea and therefore will also benefit from pulmonary rehab. The postulated mechanisms linking exercise with improved survival in lung cancer include the modulation of circulating metabolic and sex steroid hormone concentrations, immune surveillance, and reduced systemic inflammation and oxidative damage. Higher physical activity levels after cancer diagnosis are associated with reduced cancer-specific and all-cause mortality. So the American Cancer Society recommends 150 minutes of moderate intensity aerobic exercise and 2 sessions of resistance exercise per week, which is actually the same guideline for the general adult population. These recommendations are supported by strong evidence derived predominantly from other cancer populations. First of all, keep in mind that patients with lung cancer can engage in physical fitness activity safely at all stages of the disease and therapy. I just want to share this very nice article that I came across, which provided good evidence and argument on the benefits and recommended approach to exercise training across different stages of lung cancer. Exercise training is beneficial as part of the management of early-stage operable disease at a number of distinct time points along the surgical treatment pathway. This includes before surgery, in the immediate post-op, and in the longer term following surgery. Exercise training is also applicable for patients with advanced stage or inoperable lung cancer. The purpose of exercise, type of exercise training recommended, and expected outcomes of exercise and barriers to exercising at these different time points varies very slightly. Now, for patients with early stage or operable lung cancer, let's go to the term prehabilitation. In the lung cancer field, exercise training before surgery is commonly referred to as preoperative exercise or prehabilitation. However, in other clinical areas, rehabilitation is more commonly referred to a more diverse bundle of care in the pre-treatment setting, including exercise, nutrition, and psychological support. The goals are to maximize exercise capacity, minimize the post-operative burden for both the patient and health system, and to prevent post-op pulmonary complications. These are the list of absolute contraindications to prehabilitation. Usually includes the unstable cardiac condition, uncontrolled diabetes, severe orthopedic conditions that would prohibit exercise, and other metabolic conditions that will preclude a patient's enrollment to a pulmonary rehab program. In this study published last 2020, prehab or preoperative pulmonary physiotherapy was evaluated among non-small cell lung cancer with poor performance status and borderline or poor pulmonary function. The study subjected the 216 patients with lung cancer to prehab and compared the after prehab outcomes of interest at 30 days, 90 days, and 1 year. The prehab protocol done in this study included respiratory muscle training and breathing exercises, cardiovascular exercises, education such as smoking cessation, and pharmacologic agents, which include bronchodilators and oxygen therapy. The results showed that there was significant improvement in Disney scores, performance status, frailty index, and 6-minute walk test. The authors grouped the patients into high-risk patients and patients with DLCO of less than 50% and showed that in both categories, there were no significant differences in complications, length of hospital stay, or mortality rates between high-risk and low-risk patients. Prehab made previously inoperable patients operable, allowing them to safely undergo curative lung resection. However, it is currently not recommended to delay surgery in order to undertake prehabilitation, but rather use the time waiting for surgery opportunistically to deliver prehabilitation. Rehabilitation exercise prescription is generally short in duration. The exercise sessions occurred frequently during this time, and the focus of exercise prescription is to improve exercise capacity, and the prescription consisted of either moderate intensity continuous aerobic exercise or high intensity interval training, both of which could be achieved using a stationary bike or a treadmill. These types of exercise aim to increase VO2 peak, which is an important variable in patients awaiting lung cancer surgery, as it is a predictor of better surgical outcomes. In addition to walking or cycling, occasionally programs may also include whole body resistance training and or inspiratory muscle training. This is a generic prehabilitation program, so it usually includes a warm-up, aerobic strength and flexibility exercise, and some functional tasks for the patient. Now let's go to the benefits of post-operative exercise training in lung cancer. Post-operative exercise focus on recovery and rehabilitation. It's well-established, safe, feasible, and effective. And most of this post-op exercise program is similar to the traditional pulmonary rehab program for COPD. In another study published last 2021, they compared the group receiving standard of care and the group receiving intensive perioperative pulmonary rehab, evaluating the following outcomes of interest. The pulmonary rehab group received 14 pre-op and 39 post-op sessions involving education, aerobic training, resistance training for lower and upper limbs and abdominal wall and respiratory muscle training, scar massage, and group bodyweight exercise training. It showed that the PR group had a higher exercise tolerance in terms of the 6-minute walk test and significantly lower impairment at 1 month after surgery. A Cochrane review on post-op exercise training within 12 months of surgery for people with lung cancer showed that compared to a control group that did not exercise, patients who exercised presented improvements in exercise capacity, 6-minute walk distance, health-related quality of life, quadriceps muscle force, and reported less dyspnea. They concluded that PR given pre and post-operatively improved exercise capacity at 6 months and significantly reduced the decrease in exercise tolerance 1 month post-op. PR given pre-op and post-op is important in reducing physical deconditioning in lung cancer patients. In another local study of Hirado and Cabrera, they compared incentive spirometry alone versus those who underwent programmatic pulmonary rehab after lung resection. They found that post-op complications such as pneumonia, atelectasis, and retained secretions requiring intubation were higher in the group who did incentive spirometry alone post-op compared to the pulmonary rehab group. In the immediate post-op state, we can start patients on breathing techniques and with assisted range of motion exercises, since these patients will have 1 or 2 chest tubes attached. Then we gradually progress. We can advise 2 to 3 times weekly supervised exercise session and supplement it with home-based exercise to achieve 5 sessions across the week. Exercise prescription include a combination of aerobic exercise, which may be moderate intensity continuous aerobic exercise or high intensity interval training on a stationary bike or treadmill, and whole body resistance training. This is the perioperative exercise protocol that we do in our institution. During the first day, we teach them breathing exercises, range of motion exercises of upper limbs up to the pain-free range, since these patients will still have chest tubes attached to them. So we also teach them how to do coughing with splinting to lessen the pain during coughing bouts. And they are also asked to sit up in bed during meals. And then from days 2 to 4, we progress them to standing exercises and ambulation. Now let's go to the patient group with advanced stage lung cancer or those with inoperable lung cancer. These patients may be in the advanced stage or inoperable, but only because they are deemed unfit for surgery. The benefits of exercise training for advanced lung cancer include symptom improvement, prevent deterioration of exercise capacity and health-related quality of life, and to attenuate side effects of medical treatment. Although there are fewer studies for this patient group on the effectiveness of exercise training compared to those with early-stage lung cancer, any improvement or at least the prevention of deterioration in physical and/or mental outcome is of value. For patients who are in the advanced stage or those who are in the early stage but deemed unfit to undergo surgery for whatever reason, the timing of exercise training commencement can either be just before the start of medical treatment or during medical treatment. There is one study reported that only few minor musculoskeletal events such as muscle pain, but there was no serious exercise-related adverse events that were reported. So for this group of patients, we can do a moderate intensity 2 to 5 times a week exercise using the treadmill or stationary bike as tolerated. Now for the next challenging lung cancer group, those undergoing treatment or those with bone metastasis. Chemotherapy is frequently combined with long-term usage of high-dose corticosteroids, which can lead to muscular atrophy and mitochondrial dysfunction. In addition, loss of skeletal muscle has been linked to higher toxicity, that is poor chemotherapy tolerance and a poor prognosis. And exercise physically counteracts the muscle strength loss experienced during treatment. High-intensity interval training induces significant muscle adaptation and health benefits in a time-efficient manner, which has been considered safe in cancer patients during chemotherapy. Radiotherapy with concurrent chemotherapy is a standard of care for locally advanced unresectable non-small cell lung cancer. Due to the onset and progress of treatment-related side effects throughout radiotherapy, regular clinical evaluation is strongly advised in order to continuously adapt the exercise program depending on the symptoms and side effects done through multidisciplinary team discussion, including the radiation oncologist. So in this narrative review, there were limited studies available, but the primary outcome was safety, and it showed that exercise is safe in patients undergoing concurrent chemo-RT. So during chemo or RT, we can do 5 days a week of cycle ergometer for around 30 minutes for moderate to high intensity, we can include deep breathing exercises, postural drainage, incentive spirometry, active ankle and hand pumping exercise. And each session should be supervised, and for patients undergoing RT, exercise should be performed daily prior to RT. So when should we discontinue exercise in this lung cancer group? We should discontinue 24 hours after chemo if there's anemia, neutropenia, thrombocytopenia, nausea, vomiting, disorientation, side disturbances, pain in muscle or bone within 24 hours. Relative contraindications for radiotherapy or chemotherapy, for radiotherapy are radiation-induced cardiotoxicity and radiation pneumonitis. So these treatment-related side effects may occur years after irradiation in the case of cardiotoxicity and are around 1 to 3 months for radiation pneumonitis. For both cases, if your patients experience this, prolonged, continuous, and strict monitoring is necessary during exercise training. So it should be a tailored exercise prescription. So over the past 2 decades, exercise training studies in people with cancer have excluded people with bone metastasis. So this is due to the potential risk of pathological fractures, spinal compression, or exacerbation of bone pain. However, there is emerging evidence from RCTs done in cancer populations other than lung cancer that exercise training is safe, well-tolerated, and helps with preserving self-reported physical function in men with bone metastasis and no significant bone pain. The program, however, must be meticulously designed to minimize compressive and shear loads on affected muscle sites, and it should be executed carefully to avoid skeletal complications. If for patients with involvement of the pelvic, lumbar, or proximal femur, the exercise should be non-weight bearing, so we can use a stationary bike. For those with thoracic or rib mets, we can do weight-bearing aerobic exercise such as walking. Bone metastasis should not be seen as a blanket contraindication. A referral to a health professional specializing in exercise oncology, or if you have in your institution, or we can refer them to our friendly physiatrist, they should be on board with these patients. Individualized exercise programs should be carefully prescribed to meet the patient's needs and keep them as active as possible. Resistance training seen in this table provides recommendations for upper limb, trunk, and lower limb exercises according to the bone metastasis site. For example, for patients with METs to the ribs or the thorax, you can do lower and upper limb exercises with the exclusion of shoulder movement, but you can do elbow flexion and extension. However, trunk exercises is not advised. In conclusion, lung cancer and its treatments often result in physical deconditioning, reduced exercise tolerance, and impaired quality of life. Pulmonary rehab should be considered as a standard of care. It's safe, it's feasible and effective at all stages of therapy and treatment. And evidences indicate that participation in pulmonary rehab program leads to improvement in exercise tolerance, dyspnea, fatigue, and overall quality of life for lung cancer patients. Thank you, and National Pulmonary Rehabilitation Day.
Okay, thank you, Dr. Monera, for that very informative lecture. So I am inviting everyone to fill up the evaluation forms for our lecturers. And I am inviting everyone to post their questions regarding today's session. So for the next part of our session, it is an open forum. So our speakers are actually from the different regions of the Philippines, from Luzon, Visayas, and Mindanao. And most of our attendees are residents and fellows in training, including respiratory therapists. So I would just address some questions to our speakers. So may I ask, siguro this one would be addressed to all of them. So what are the struggles and barriers that you have encountered when establishing a pulmonary rehabilitation facility? Probably you can share your insights with this one. Siguro I'll start with Dr. Karen Claridad.
Okay, good evening once again. So the main struggle that one, this is in establishing a pulmonary rehabilitation program, right?
Yes.
So, okay, in establishing a program, you really need to have a pulmonologist specializing in pulmonary rehabilitation is not enough because you really have to have good respiratory therapists or physical therapists that are trained for your to do pulmonary rehabilitation. Otherwise, you're going to do all the rehabilitation for all of your patients, which is technically not possible in the long run. So you have to train your own respiratory therapists. Now, the good thing about here in our country, there are institution, Philippine Heart Center for one, Lung Center of the Philippines also offering training to respiratory therapists. So if you want or if you're planning to establish a pulmonary rehabilitation program, so you have to send your respiratory therapist for training, or you can train them yourself. Okay, if you because you need really good respiratory therapists.
Okay. Thank you, Dr. Karen, for that meaningful insight. So I would agree with you, Pudok. So since respiratory therapies are composed of one of the huge part of establishing the pulmonary rehabilitation facility, so it's a good thing that you were able to emphasize as well that there are certain institutions who offers programs for our respiratory therapies. I think Dr. Omohaire can share also her insights regarding this one.
Actually, we do not have a pulmonary rehab program yet here in Davao City. And so we hope to be able to create a pulmonary rehab program here soon, no? So I think, apart from logistics probably, and then starting really you need, because again, it's a multi specialty, it's not just pulmonary physicians, as what Dr. Karen has mentioned, no? You need therapies, your dietitian, nutritionist. It's really a team effort. And so that's the difficulty there. But I think that's just the starting is the difficult thing. But once you get it rolling, right, Dr. Karen, in your place, then I think with the support, I think this is a good thing because the support of the PCCP, and we also have institutions such as Heart Center and Lung Center who offer trainings for our respiratory therapists who always work hand in hand with us in our pulmonary rehab program. So I think that will make things easy. So here in Davao City, we do not have a program yet, but I hope we will be able to create one soon. Thank you.
Okay, thank you, Dr. Omo, for that insight. So I think Dr. Monera is based in Lung Center of the Philippines. So I think she can share some of the struggles that she was able to overcome when establishing the pulmonary rehab.
Actually, sir, we already have the pulmonary rehab program that we have in Lung Center initially started as a support group, which was way back 1994. So it was already established that time, and we just fine-tuned it. Basically what we need is the support from the institution first. And then again, the staff that you need to have physical therapists, respiratory therapists, nutritionists. You have a psychologist, that would be better, social worker. And then the next would be the patient information. They don't know what pulmonary rehab is. We don't get referrals. So mainly it's on how we will promote pulmonary rehab program. So basically we get patients from the outpatient service department, and then we get referrals from them, and then the group became bigger until we have several hundreds, I think, of support group members right now. So that's
Okay.
it.
Thank
Yeah.
you, Doc. Thank you, Dr. Nice, for that insight. Actually, that was my follow-up question. So, pulmonary rehabilitation has been in the Philippines since the 90s, yet there are only a few healthcare providers as well as patients are aware on the role and indications for the pulmonary rehab. So, I think for a follow-up with Dr. Nice, how can we promote awareness on the role of pulmonary rehabilitation, especially in our healthcare system?
I think it would be number one is with a partnership with the PCCP. So that's number one. And then mainly we just tell our colleagues. Sometimes even the pulmonologists themselves, they don't know what pulmonary rehab is. So it's mainly on education. And then once we have our own referrals, we can teach them. And then these patients will cascade the message to other patients who have the same illnesses as them. So really it's by word of mouth, it's by education, not only the patient, but also our colleagues.
Okay. Thank you, Dr. Nice, for that very
Doc, I'd
meaningful
like
insight.
to add also on
Okay,
that,
Doc.
regarding what Dr. Nice said. No, it's really true, no? The awareness regarding pulmonary rehabilitation must be extended not just to the patients, but also to our colleagues, to our pulmonologists as well, because it's true that some pulmonologists are actually non-believers of pulmonary rehabilitation. So we really need to spread awareness to our colleagues, because based on experience, some pulmonologists are not aware regarding the benefits of pulmonary rehabilitation and what it is. And then once they get to experience maybe just one referral from them, and then the patient will really like have positive feedback regarding the pulmonary rehabilitation, that one consultant, that one pulmonologist will tend to refer more patients in the long run. So I think maybe awareness and PCCP is really on the works right now in spreading awareness to among our colleagues regarding pulmonary rehabilitation.
Okay. I would actually agree that we should go back to our mother institution, our mother society regarding this problem. No, so I think PCCP has been promulgating some efforts in order to promote pulmonary rehabilitation in the Philippines. I think Dr. Omohaire can also share her insights regarding awareness, especially in Davao.
Yeah. So very correct, no? Not only in the knowledge of the patients, no, because who sees these patients? It's us, the pulmonologists, and so that's why I mentioned in the start of my lecture that I hope that we will be able to convince more pulmonary physicians to start to make use of the pulmonary rehabilitation program. So I think that's one aspect that we should be looking into us in our group and our council, no? Maybe we can do a study and look and ask, no, about the knowledge and the behaviors of our colleagues, our pulmonologists in their apprehensions. Why are they hesitant to refer? No, previously there an issue rose that some that they did not want to refer because of fear that their patients will no longer go back to them. So is that one? I know that maybe we can address that as well. So I think that's just my 2 cents.
Okay, thank you, Dr. Omo. So there are actually some questions that are posted online. So for all these speakers, how can we make pulmonary rehabilitation accessible for more patients, especially at the community level? This is also in the purview of the universal healthcare law. So what are your insights regarding that?
I think, yeah, go ahead.
Go ahead, Doc.
Right, good.
I think one effective mode of delivery would be really through telerehabilitation. So I find it really effective on our patients. But of course, like what I mentioned in my lecture, that I find it more comfortable if we were able to see the patient face to face on the initial assessment, and then later on, all of the rehabilitation sessions can be done through telerehabilitation. It's really feasible. So it will be more convenient, and then much more the completion rate of the patient is really high with telerehab.
Okay, thank you.
One barrier also in terms of the accessibility is also the cost of the rehabilitation. So that's actually one of the major issues that we get to encounter. But you know, we have institutions, private and government institutions. The government institutions are actually birthing right now, providing really affordable pulmonary rehabilitation programs to our patients.
Okay. I think Dr. Nice is about to share.
Yeah, I was going to say the same. Telerehab is one since internet it's very accessible to other uh people outside of Metro Manila since most of the institutions offering pulmonary rehab is based in Metro Manila. And then uh in maybe we can make it part of the PhilHealth package to make it, I don't know, maybe it's one that we can do that it will at least decrease the burden to those who want to have an access to it.
Okay, thank you. Thank you, Dr. Monera, for that insight.
Also, can I just ask? No, I'm going to be the one asking the question to Karen and Nice. Could you tell us, like, in your institution, what is the cost of the pulmonary rehabilitation, so that we have in our group also not only fellows in training, but also some respiratory therapies, so that we have an idea really how much that costs, no? Like in lung center, how much does the
Doc, for in lung center, actually it's an advocacy, so it's very cheap in lung center. So we offer it at 1,000 pesos for 9 sessions. Actually, it was before we Dr. Cabrera, what she did was gave it in a longer time. However, the uh the rate of patients complying to the 2 or 3 month program is very low. So what she did was make it a 9 session program, just 1 month, a little over a month, twice a week. And then we asked them to pay 1,000 pesos for it because it's an advocacy. Mainly that's it. But we also offer one-on-one for one-on-one pulmonary rehab. The same goes if for virtual. We for the support group that we have, we offer it at the same rate. They just join. We do a hybrid program, and then some patients use the malasakit program, so they get discount for it.
Thank you.
Okay, thank you. Thank you, Doc, for that very meaningful insight. So another question, I think all of our speakers have different institutions where they had their clinical research fellowship or sub-fellowship program. So there's a question posted, which institution locally or abroad offers pulmonary rehabilitation program training, which can you recommend? I think Dr. Karen had it internationally abroad in South Korea.
Yeah,
So if you can share her experience.
in Asia, okay, there are I think two countries which offer pulmonary rehabilitation training. So one is South Korea, and then the other one is in Taiwan. So in South Korea, they offer it in Yonsei University, and in Taiwan, I think at National Taiwan University Hospital, NTUH. And I think Dr. Punzal also is familiar with one institution in Hong Kong for pulmonary rehabilitation. And yeah, that's for Asian countries. And then Dr. Nice had hers in Canada, right?
As far as I know, they don't offer a formal pulmonary rehab program. So mainly it's an observership specific for lung transplant. But as far as I know, I'm not sure I think in the US they do. I'm not so sure in the US. I think Dr. Pansal knows.
Okay. Thank you, everyone. So for the last question, is there a list of pulmonary rehabilitation programs? So PCCP head office has actually posted the list of the contact details and the specific institutions who are able to conduct pulmonary rehabilitation. So this includes the Asian Hospital, Cardinal Santos, Chonghua Hospital, Cebu Doctors, Lung Center of the Philippines, Perpetual Health Medical Center in Las Piñas, Philippine General Hospital, the Philippine Heart Center, St. Luke's Medical Center in QC and in BGC, the Medical City in Pasig and Iloilo, University of Santo Tomas, Veterans Medical and Memorial and Medical Center, Vicente Soto, and Western Visayas Medical Center. I think those are all of the institutions who are able to cater pulmonary rehabilitation. Okay. And for the last part of our session, may I call on Dr. John Clifford Aranas. So Dr. John Clifford Aranas, to summarize the gist of today's session. So he is a fellow of the Philippine College of Chest Physicians. He had his adult pulmonary training in adult pulmonary medicine and pulmonary rehabilitation at the Philippine Heart Center. He is the current chair of adult pulmonary fellowship training at the Perpetual Succor Hospital in Cebu City, and he is a member of the Board of Trustees of the Philippine College of Chest Physicians.
Good evening, everyone. Happy National PR Day. What a great way to end the luncheon. So at dinner, we had just 3 full servings of pulmonary rehab topics. So if you allow me some liberties of rearranging the sequence of the presentation. Dr. Dilangalen set her sights specifically on the benefits of PR in patients with COPD. This is a subset of patients that form the bulk of the PR population. It is this group of patients that have provided us with the most information and the biggest source of data on the benefits of PR, providing a fertile ground from which current practices in rehab have sprung, and they will continue to grow as the indications of PR have also grown to include practically any lung disorder that they may cause physical disability. And then Dr. Claridad discussed the indications of PR and how PR is done here and abroad. He also enumerated barriers to instituting rehab, barriers that are actually universal and not just experienced here in the Philippines, and how to address these barriers by utilizing available resources and technology to make PR more accessible to patients. Examples of these are community-based PR, tele-rehab, web-based rehab, and even with the use of booklets or visual guides for the non-tech-savvy patients. More importantly, it was shown that they are effective face-to-face and person-to-person or in-hospital pulmonary rehab, proving that distance and proximity should not be deterrents to PR. So it just needs to be done. And then lastly, but not the least, Dr. Monera narrowed down PR to the context of patients who have lung cancer, to encompass the different stages of the disease, even among those not fit to undergo curative surgery, and even those with bone metastasis. This is very important, most especially here in the Philippines, because much of our efforts in treating lung cancer is aimed at improving survival, and that focus might be so narrow, it creates a tunnel vision to the exclusion of other aspects of treatment, like addressing disability and exercise limitation, not just cancer survival. So, by way of summarizing all the topics, I'd like to emphasize the important points of the 3 topics discussed. Number 1 is the importance of PR in patients with disabilities due to respiratory disorders, even in those with lung malignancy who are deemed at a distinct disadvantage in terms of survival. PR should be part of the treatment options for any patient with disabilities due to chronic lung problems, taking into consideration specific needs as well as challenges or barriers to delivering PR services. PR should therefore be prescribed with pharmacologic intervention rather than considering it after pharmacologic prescription fails to result in optimal outcome. While there may be barriers to PR, these barriers are better considered challenges that can be overcome. I think that's it. No? Thank you very much to our audience and our participants.
Thank you po, Dr. Aranas, for summarizing tonight's lectures. So for the awarding of the Certificate of Appreciation to our speakers, so first would be for Dr. Karen Ann Claridad, for sharing her knowledge and expertise as the speaker on advances in pulmonary rehabilitation, contemporary practices in the local and global settings. Next would be for Dr. Omohaire Dilangalen, so for sharing her knowledge and expertise as a speaker in optimizing COPD management and the role of exercise and rehabilitation. And last would be to Dr. Onaizah Katrina G. Monera for sharing her knowledge and expertise as speaker on integrating exercise in lung cancer management approaches and benefits. Okay, so for the last part, I would like to call on Dr. Benedicto, the PCCP Vice President, for his closing remarks.
A pleasant evening to everyone, and thank you so much for the Pulmonary Rehab Council for this wonderful session. Indeed, it is a welcome respite from the usual topics, and now we come back to the basic, how to restore the energy that we have within us and translate this to better outcome. Certainly, one of the most overlooked intervention is that of pulmonary rehab, and it is quite unfortunate in that instance. As what we saw from the three speakers, integrating pulmonary rehab in our approach to chronic pulmonary disease like COPD and possibly making it an integral part of management is very vital to ensure the well-being of our patients. Again, thank you so much for this wonderful initiative. And I certainly look forward that this National Pulmonary Rehab Day will be part of the usual celebrations per year, as this will showcase a very important intervention that should be accessible for all. Again, thank you for this wonderful session, and for all the participants, I hope you had a fun time learning. Good evening.
Thank you, Dr. Benedicto, for closing tonight's session. So I would like to personally thank Dr. Punzal for his hands-on guidance, not only for tonight's session, but most of the activities in terms of celebration of the National Pulmonary Rehabilitation Day, as well as the 300 participants for tonight's session. Okay, thank you and good night, everyone.
Pulmonary rehabilitation is a comprehensive program based on a thorough patient assessment and individualized treatment. It is designed to improve both the physical and psychological conditions of people with chronic respiratory diseases.
This clinical program is indicated for patients with chronic respiratory diseases like COPD, bronchiectasis, lung cancer, interstitial lung disease, and asthma.
The essential components of the program include the following: education, exercise training, and psychosocial support.
Pulmonary rehabilitation improves the patient's exercise capacity, quality of life, reduces exacerbation and hospital confinement, and can lead to a reduction in anxiety and depression.
Di na kami nag-iisa.
Kasama na namin ang pulmonary rehab. Tara na!
Let us all join hands and celebrate the National Pulmonary Rehabilitation Day.
Happy National Pulmonary Rehabilitation Day!
Breathe better. Live better with pulmonary rehabilitation.
Relax.